Next, we'll discuss assessment of the thyroid gland. In testing thyroid gland function, there are several tests that can be performed, and so here's a general schematic of the hypothalamic pituitary thyroid axis, and each of those lab tests is numbered on this diagram. So the first potential test is TSH itself. The second one is T4 and T3 bound to thyroid binding globulin. The third is free T4 and free T3. And the fourth are various thyroid antibodies, and the fifth category is thyroid tumor markers. So now let's look at each of those lab tests individually in more detail. So let's start with TSH, and TSH is a protein or a peptide with a structure similar to FSH, LH, and beta-HCG, a placental hormone, at least in terms of its alpha subunit. And that's what's shown here in red. So TSH does have a unique beta subunit, as do each of the other hormones mentioned, and that's what provides the receptor specificity. TSH function, as you might expect, is to stimulate growth and vascularity of the thyroid and to specifically stimulate formation and release of thyroid hormones through upregulation of iodine uptake into the gland, through increased thyroid peroxidase activity and increased lysosomal activity, which allows thyroid hormone to be more readily released into the bloodstream from follicular cells in the thyroid. TSH secretion is relatively stable throughout the day, which is different from what we saw with ACTH, LH, FSH, and several other pituitary hormones. And this does make its measurement significantly easier to interpret. We can also measure T4 and T3 as well as the free forms of these two hormones. And so T4 is the main hormone released from the thyroid gland, approximately 80 micrograms released per day in the average individual, but it's 99% or more bound to protein. And approximately 30 micrograms of T3 is released per day, and it too is extensively protein bound. So what are these proteins that are bound to thyroid hormone? So the most prevalent is thyroid binding globulin, or TBG. So be careful not to confuse thyroid binding globulin with thyroglobulin, which is the pink colloid type material seen on the earlier histology slide. In addition, 15 to 30% of thyroid hormone is bound to transthyretin and a smaller percentage to albumin. So if you want to get an idea of the free or most active form of thyroid hormone, you may need to measure free T4 and free T3 in some circumstances, even though they only comprise about 1% or less of the total amount of thyroid hormone in the bloodstream. So here, when we use the term biologically active, we mean that free T4 can be converted to T3 for entry into cells and that target action. And we mean that the free T3 is the form of T3 that actually enters the cells and exerts target action. So it's important to know something about thyroid binding proteins, specifically thyroid binding globulin, since it's the most prevalent. And that's because changes in these binding proteins will affect the measurement of T4 and T3 without actually causing any biologic changes in the person, meaning they wouldn't actually have a thyroid problem. And here are acquired and several inherited causes of binding protein abnormalities. Acquired are far more common. And some things that can increase thyroid binding globulin or binding proteins are drugs such as estrogens found in oral contraceptive pills and opiates. Pregnancy will increase thyroid binding globulin and result in an elevated total T4 or T3 measurement. And acute stages of hepatitis can increase TBG. On the other hand, decreased binding protein or decreased TBG can be found with androgen use, glucocorticoid or steroid use, and other states here including malnutrition, chronic liver disease or cirrhosis, and renal disease. There are also some rare inherited causes, including TBG deficiency and mutations in TBG, which can affect thyroid hormone measurements but cause no clinical syndrome in patients. And so endocrinologists and physicians tend to rely pretty heavily on TSH to diagnose and follow primary disorders of thyroid function. And this graph should help us understand why that is and why TSH is so critical to assessing thyroid function. So the first reason is that TSH reflects long-term feedback of thyroid hormones on the pituitary gland, showing what the thyroid levels have been doing for about the previous 6 weeks before measurement of TSH. And the other reason that TSH is so useful is because the changes in the thyroid hormones themselves will cause an opposite and a logarithmic change in TSH. So let's look at that on this graph. Free T4 is shown on the x-axis, and as free T4 levels increase into the hyperthyroid range, TSH levels on the y-axis will decrease, but not in a linear fashion, in an exponential fashion. And the same occurs if thyroid hormone levels decrease. So if free T4 were to decrease by only 2-fold, the TSH would increase by over 100-fold. So TSH becomes an extremely sensitive test in diagnosing thyroid disease. TSH, T4, and T3, and free T4 and T3 are the main measurements used for assessing thyroid function, but thyroid antibodies can also be measured. They aren't stable tests, but they can be used in specific situations. And the 3 thyroid antibodies to discuss are thyroid peroxidase antibodies and TSH receptor antibodies, which are generally implicated in states of thyroid hormone deficiency or excess, and thyroglobulin antibodies, which are much less specific, and they're made by a portion of the population but aren't pathologically implicated in disease states. So the first 2 antibodies are thought to play a role in autoimmune thyroid disease, which is much of the thyroid disease present in the Western world. And some of these antibodies, specifically the TPO antibodies, can stimulate or block thyroid cells or receptors on thyroid cells, resulting in cell lysis and inflammation and altered gland function. And so some of these can be useful in mild or early autoimmune thyroid disease. Let's look more closely at thyroid peroxidase antibodies. And TPO antibodies are directed against thyroid peroxidase, the enzyme in thyroid follicular cells that facilitates several steps in thyroid hormone synthesis. So they can be found in 90 to 95% of patients with autoimmune thyroid disease, particularly patients with autoimmune thyroid failure or hypofunction of the gland. And TPO antibodies are often present before thyroid dysfunction develops, and they may cause a cytotoxic or destructive process, but may also exist without ever causing any thyroid damage. So low levels of these antibodies exist in approximately 12% of normal individuals who don't develop thyroid disease. And this means that no treatment of antibodies is required just because they're present, as long as thyroid function is normal. And so the graph on the right just shows that the prevalence of thyroid peroxidase antibodies increases with age in patients who have Hashimoto's disease, or another term for patients with autoimmune hypothyroidism. Turning now to TSH receptor antibodies, or TSHR antibodies for short. There are 2 varieties of these. One is thyroid stimulating immunoglobulin, or TSI, and the second is TBII, or thyrotropin binding inhibitory immunoglobulin. The name of each of these gives us some clues about their potential actions. When they bind the TSH receptor on thyroid follicular cells, they can either stimulate the action of TSH on a thyroid cell in the case of TSI, or block it in the case of TBII. Sometimes, however, they can be present in the bloodstream without having any effect on the thyroid. And they can be used clinically in patients who have hyperthyroidism of unclear etiology, because the presence of TSI would help one to diagnose Graves' disease or autoimmune hyperthyroidism. They can be particularly useful in pregnant patients who might have Graves' disease in order to detect whether the fetus is at risk for hyperthyroidism from antibodies crossing the placenta, because during pregnancy, other tests involving radiology and nuclear medicine are unable to be performed. And finally, this is the last test that can be used in assessing the thyroid tumor markers. And these include both thyroglobulin and calcitonin. And thyroglobulin is simply a normal protein found in follicular cells of the thyroid, as we discussed earlier. But it can also be used in surveillance of papillary or follicular thyroid cancer, so PTC or FTC, after these cancers have been treated with surgery and any other potential modalities. Patients who have a low or undetectable thyroglobulin are thought to be free of disease, whereas patients with rising or elevated thyroglobulin may have leftover thyroid tumor cells in some cases, or just leftover normal thyroid cells. The one caveat to measuring thyroglobulin in these patients is that it's not reliable in a small subset of patients who make thyroglobulin antibodies, which interfere with the assay. And calcitonin is also a normal protein found in all individuals because it's produced in the C cells of the thyroid. But it too can be used as a surveillance marker, this time in patients with medullary thyroid cancer, or MTC, which is a less common thyroid cancer, after it's been treated with thyroidectomy and other modalities. A low or undetectable calcitonin suggests that the disease is in remission, and a high or rising calcitonin suggests that there are some leftover tumor cells. And the caveat with calcitonin is that it can be elevated in many other conditions that have nothing to do with a thyroid cancer, such as liver and breast cancer, carcinoids, Zollinger-Ellison syndrome, and pancreatitis. And so this is why calcitonin can't be used for diagnosis and should only be used for screening after a patient's thyroid has been removed. And even then, if there are minor elevations, other sources may be implicated. So both thyroglobulin and calcitonin, it should be emphasized, are used for surveillance and are not very useful if measured in normal individuals who have not yet had their thyroids removed, because most normal individuals will have detectable thyroglobulin and calcitonin if they have a native thyroid.